So now it's my distinct honor and privilege to introduce the person we're going to start this conference, Dr. Laura Cheever, who is really one of the people responsible for why we are here. As the Associate Administrator for the HIV/AIDS Bureau of HRSA, she is really tasked to provide the leadership and the technical advisory for this Ryan-White program. So there couldn't be anybody better to give this talk. Dr. Cheever.
Thank you. Thank you so much for that introduction. I am, once again, very excited to have you all here today, and I want to start off by just thanking all of you. I've worked at the HIV/AIDS Bureau for 23 years, 24 years almost, and I came to stay for 3 to 5, and I stayed this long because the Ryan-White program is so amazing, and it's so amazing because of what you all do every single day in your community. So I think we should give you all a big round of applause. So I'm a Fed, so I have no financial incompatibilities. Learning objectives are really to talk about the policy priorities we have, what we're doing in terms of programmatic focus, and some information about our data. And I expect all of you hopefully are using data in your daily work and certainly in the programming of your clinics. Our vision is optimal HIV and care treatment for all to end the epidemic. And in the Bureau, we really think that we really focus on providing both leadership and resources. So not just grants, but providing that leadership and backbone to help drive down disparities and improve outcomes. So starting with Bureau updates, this is just a snapshot of the Ryan-White budget since 1991, the first year it received funding, until 23. We don't have a 24 budget yet in place. And a couple of things you can see here. So the top line that sort of takes off in 96 is the AIDS Drug Assistance Program, which really came into being with the advent of highly active antiretroviral therapy. So about $900 million in federal funding goes to that, and by far the biggest chunk of the Ryan-White program. The next line is the Part A program, which is funding to highly impacted cities. The next line down, the red line, is I have a pointer they said this year. This is exciting. So the red line is the Part B program, which means for states that don't have highly impacted cities, there's not a ton of funding for care and treatment services in those states. There is some, but not as much as in places where they have highly impacted cities. This is the Part C program that Captain Mofidi runs, and many of you work in Part C programs, directly funding to community organizations and clinics to provide HIV care. And this is CAETC, SPINS, and the dental program. This new little line is ending the epidemic program. So you can see that this is a new program that was started in 2020 and really received a teeny amount of money. And I want to point this out now because I'm going to show you some of the impact that funding's been able to have. I think the most important thing I would take away on this slide is that if you look, the Ryan-White program has essentially been maintained since the early 2010s. Which means that you all have been doing increasingly more and complex work with the same amount of money. And that is a tough situation. You've managed it well. I certainly think the Affordable Care Act, where it's expanded, welcome North Carolina, where it's expanded has really allowed all of you to leverage some of your money differently if you have more people covered. In terms of what you all did in 2022, and I want to thank you because we have these data because you all submit client-level data to us. The Ryan-White program served over 500,000 people, which is over half of all the people with diagnosed HIV in this country. So really a profound influence on who gets treated. And this program is meant for low-income people that don't have adequate health care coverage. And in fact, if you look at the people we serve, about 12% of them have stable or unstable or temporary housing. And about 60% of them live at or below the federal poverty line. So in fact, we are reaching the population we're intended to reach. 3/4 are racial or ethnic minorities. And a new fact, which we're really excited about, is that almost half now in our program are over 50, which is a huge success. in terms of people living longer, healthier lives with HIV, but also poses a lot of unique challenges that we are coming to understand and really trying to figure out fully, both in terms of the medical management and in terms of the model of care that we have in the Ryan-White program. It's changed dramatically and will continue to change over the next decade. We'll be talking about that quite a bit during the conference. And exciting, about 9 out of 10 people in medical care in the Ryan-White program are virally suppressed. So super, super exciting that we've achieved that, and we'll talk about some of the improvements we've had. But that's in a backdrop of about 67 or 68% of people being virally suppressed among all those diagnosed nationally. And that big difference is because so many people are diagnosed and not receiving services. And I know many of you have seen those people come in and out of your clinics over time. And that's the new work, really the next work we need to do in the Ryan-White program if we're going to end the epidemic in the United States. So this slide I'm going to spend a little bit of time on because it's a really important slide. So this slide compares viral suppression in the Ryan-White program nationally among various subpopulations, comparing our 2010 data with our 2022 data. So if we start here at the first set of bars, the gray represents the viral suppression rate nationally in 2010. It was about 69.5%. And this dotted line is comparing different subpopulations. So you can see Hispanic, men, MSM, people who inject drugs, Black, African American, transgender populations, youth, and unstably housed. And you can see that we have some big disparities in many of these populations. We turn now to 2022, our viral suppression rate is 89.6%. So 20-point increase over these 13 years. So huge increase. Some of that's because the drugs have gotten easier to take, and some of that is because you all are doing your work differently and have found different ways to reach people and keep them in care. And then when we look across in 2022, comparing different viral suppression rates, you can see for youth, for example, their viral suppression rate was almost 84%. So we had a 20% improvement nationally overall. We had a 37% improvement among youth, which means we've significantly reduced that disparity. Now the disparity is still there, but we've significantly reduced it. Similarly for transgender folks, for Black people, we've been able to reduce the disparities, but those disparities remain. The least progress we've made overall, when we looked at our data, has been among those that are unstably housed. And the unstably housed need to get stably housed. That's probably the most important intervention. There are obviously other things we can do and have done. But we still have work to do here, but you should be really proud of the fact that you've been able to focus on key barriers and challenges people have and work to address them differently. Getting to that, a great way to learn about ways of delivering our services differently is attending the 2024 National Ryan-White Conference. So this is the national conference for the entire program, not the clinical meeting. It's going to take place in a hybrid format, which means in-person and virtually, August 20th through 23rd. The in-person session will be at the Marriott Marquis. We anticipate about having 3,500 people attend in person. I don't know how many will attend virtually. It could be up to 5,000. We had about 8,000 attend virtually a couple of years ago. And we're going to focus on how to end the epidemic, innovations we need, including working differently with communities, empowering communities, expanding partnerships, doing our work differently with different people to get this different result and reach those out of care, and implementing interventions that we know work. So I would encourage all of you that are interested, next slide, to submit an abstract. Abstract submission is now open and will close on December 15th. We are asking people that are going to, that are presenting orally to be in person. And we're also piloting a subset of our abstracts to be presented in Spanish to really expand the reach to people who may not feel comfortable presenting in English. And we will have both Spanish and English translation at the meeting. So turning now to policy updates. I hope all of you know what the Medicaid continuous enrollment is, but maybe you all don't. So I'm just going to briefly say that during COVID, Congress and Centers for Medicaid and Medicare Services worked together such that people on Medicaid were not kicked off because they did not renew. There weren't renewals during that time. And it really allowed more people to stay on Medicaid and have less interruptions during that really chaotic time. However, that all ended last spring. And so people can now renew, and every state is doing it in a slightly different timeline, but will happen over the next year. So we have, in the first look at the data, about 42% of renewals have been successful. People have kept their Medicaid or CHIP coverage. 37% of renewals resulted in someone losing Medicaid, and of those, 3/4 were because the person didn't return the renewal form, had something wrong or incorrect on it, et cetera. So that is really frustrating for me, because when you have more Medicaid coverage, it means the Ryan White funding that you all have can go further. So we really need to continue to work on renewals. We'd worked very closely with many of your programs to try to make sure you all were as ready as you could be, as case managers and other people once again went back to that hard work of getting people's renewals in order. Also, in this past year, we've released 4 program letters. Now, program letters are when we want to highlight a new trend. It's not a policy from us, but highlight a new trend that we need you all to be aware of, or if we hear repeatedly that people don't seem to understand fully about how the program works, and there's an opportunity for improvement, we'll highlight that as well. So we had 4 letters. The first letter was talking about the HIV outbreaks that were occurring across the country that fairly consistently were occurring primarily among people that were unstably housed. And so this was a letter we released with CDC and HUD to talk about housing and focusing on housing in HIV outbreaks, focusing on it early, both for people who had HIV and for people that were at high risk of HIV. Because if we can get them housed, as you all know, they're gonna do better in terms of their HIV, and they're gonna be less risk of acquiring HIV. So that was the first letter. The second letter actually came from a comment someone made to me at this meeting, which is my state ADAP, I won't say which one, East Coast ADAP, doesn't cover STI medications because they say that's not really what they do. And so I went back to our group and said, do ADAPs not cover STI medications? So we did an analysis, and several of them did not, and we talked to them about what the issues were. And they said, yeah, we don't, it's repair of last resort, other people can do that. So we put out a letter that really was for all clinicians about the importance of addressing STIs and HIV care and treatment, which is pretty obvious, I think, given this endemic, but particularly the overrepresentation of men with HIV among people that have STIs. Really important that we are on that. But particularly, we pointed out that ADAP should cover STI medication for people that can't otherwise get it, because it makes it much more seamless in programs. So that was a comment from here. So please, as you all see things that you don't understand and you want to fix, that's why Captain Mofidi and I are here, is to talk to you all. So please approach us to talk about some of those things. Some of those things we can't ferret out, it's a local decision, but other things are much more systemic that we can definitely help improve. The third letter was about a substance use disorder, and particularly that ADAP should cover medication-assisted treatment and naloxone as part of what they do. And the fourth letter was we did in conjunction with the Indian Health Service, where we really focused on those counties and jurisdictions with high rates of congenital syphilis in the native population, because it had increased 900% congenital syphilis for Native Americans between 2016 and 2021. It's gone up for everyone, but 900% was just outstanding. 10 times the rate it would be in whites. And so to really make sure our Ryan recipients were aware of that, and we're working on that issue. We also developed a quality of life framework. We heard from older people, we heard from youth, and we heard from women with HIV all that their quality of life sucked, even though they were in the Ryan White program, and what could we do about it? So we went back, but each of those different groups of people that were talking to us had different definitions of what is quality of life. So we went back and sort of mapped out quality of life based on some of the literature, what made sense in the context of Ryan White, the physical, emotional, social, environmental, and structural domains, and then mapped out really what Ryan White service categories and services you can use to augment quality of life in these different areas. So it was really a tool for different recipients as they wanted to focus on quality of life or heard about quality of life from their constituents, what sort of a mapping of how Ryan White could help them address some of those issues. Ryan White is committed to quality of life. I think the area where we obviously have the first and foremost area, which often gets forgotten, is in the physical. People that are doing well medically have higher qualities of life, but there are lots of other domains that we have an important role to play. So So turning now to our program activities. One of the areas of focus for us this year is streamlining eligibility across the Ryan White program. We have heard over and over again that people fall out of care because they show up at the pharmacy or wherever else and are told their Ryan White has expired. In 2021, we had a policy clarification notice that people were not required to do a 6 months recertification, that if a person didn't recertify on whatever date the state or city said they should, that they should try to give them some grace and a way to work it through. And so we met to really talk about what was and wasn't working with that, and best practices. And some states and cities have amazing ways of linking eligibility and making sure that people are engaged in renewing their eligibility as they need to. So we got some of those best practices, and we'll continue to work this year on helping people to improve that eligibility system and reducing the barriers that we can on our end. We've also worked on a status neutral approach, which is we released a funding opportunity. And this, for those of you that don't know what this is a concept that, for example, a very high-risk person like a transgender woman might come in to get HIV tested someplace. If she tested positive, she had a full array of services, right? She would sort of go into the loving arms of Ryan White. And if she tested negative, she'd be told to come back in 3 to 6 months in a lot of testing sites. And CDC said, no, we really need that person to be referred to risk reduction in a number of ways, PrEP, et cetera. How do we tie that all together? So some jurisdictions have done this very well. Clover Barnes, are you in the house? I heard Clover was coming. You can stand up if you're here, and maybe she's not here yet. Oh, right there in the back. There you go. Clover, everyone see who she is? So she runs the Part A program in DC, a Part A and B program, and they really have woven together their prevention and care resources so that when someone comes in, they get sort of full person care. And this is funded through the Minority AIDS Initiative funds because we cannot fund medical services for people that do not have HIV in the Ryan White program. This is not taking money away from people with HIV, but we want people. We think it'll help reduce stigma if someone can come into a service center and it's not labeled HIV, not HIV. It's labeled, come in. You need care. We can care for you, and then person can get a full array of services. But it really requires a lot of braiding of funding at the local jurisdictional or clinical level. So we funded an opportunity to do that. And we funded 4 sites to implement these activities, 4 jurisdictions you can see here, and an overall evaluation and technical assistance provider to help them figure out how to weave together those kinds of services. We continue to work on implementation science, the concept of finding out what works and spreading it to clinics, like having it in a place that someone can say, I want to do better around people with incarceration experience. How can I better link to my jails? So you find an evidence-informed intervention of someone who's linked successfully to jails, and you package it in a way that another clinic can pick it up and say, oh yeah, this is something I can do. These are the 4 things I need to think about. This is the data use agreement they had, whatever that package of issues are. So we funded another innovation in that around 4 different areas: people with incarceration experience, LGBTQ youth, people with substance use disorder, and better utilizing and more effectively using telemedicine. So those are funded now. And we have a best practices compilation, which is where we spend a lot of time and a little bit of money to make sure that as people have these evidence-informed interventions, they're packaged in a way that's easily searchable for you all. So if you go to targethiv.gov, you can go to the best practices compilation and search for something that works in a Part C clinic or in a community-based program or a health center that is working specifically on better engaging people who use drugs or better engaging youth, whatever the issues are on. Also things around managing your grant, like how do I do better fiscal management of this particular issue? If you go to the best practices compilation, you'll find many best practices there that have really been curated, and we continue to add more every year. We also have a Part D communities of practice up and going. 2 years ago, we spent quite a bit of time talking to our Part D program about what we could do to help them become better at the things they need to work on, and started a community of practice that's been incredibly robust today. The first year was focused on the first community of practice on preconception counseling, including sexual health. The second one is on youth transitioning from youth services to adult. And the third is going to focus on trauma-informed care. And once again, Dr. Mofidi over there can tell you a lot more about those if you're interested in joining your Part D program. Quality improvement, I think, has been a cornerstone of how we do the work that we do and why we've made some of the improvements we've made. And we started a collaborative right now that's really focused on those clinics, 30 providers, who had the most area for improvements. And that's ongoing. It's 18 months really focused on them learning. A lot of them did not know a lot about quality improvement and how to have those practices integrated into their clinic. So that's the current one, but if you're interested in joining a quality collaborative, there'll be a different one in the coming year. We worked on modernizing the AIDS Education and Training Centers program, once again talking extensively to the AETCs, to many of you, to the Part A's and B's, because the workforce, I think, our workforce issues, as I've already alluded to once today, are really I think they're really the Achilles heel of the work that we're going to try to do in the next 10 years. So we are recompeting them, both the regional one and the National Support Center for the ATCs. Those two competitions are up right now, so I can't talk a ton about them. But if you're interested, I would encourage you to look at those NOFOs and to consider applying. So next, a few data updates. We do want our data to be readily accessible. We've created a dashboard a couple of years ago called Compass Dashboard, which has service data as well as demographic data and outcomes data in various jurisdictions. If you are a recipient, you can actually see your data compared to a like-matched recipients across the country. You can compare your data to others similarly situated to yourself. So I would encourage you to look at that if you haven't. It runs much faster now than it used to. It's significantly, I think, better in terms of performance. We have lots of data resources available. Our data report, slide decks, and again, our Compass dashboard. So I'm going to end with ending the epidemic in the United States. So this was an initiative that's been relatively small in its funding, started in 2020, that has multiple components to it. Really, the essence of it is that we do have tools. We have the tools in the United States to end the epidemic. That's been modeled a couple of different times in different ways, between getting more people tested, getting people in care and virally suppressed, which means they can't transmit HIV sexually, and better use and expanded use of PrEP, as well as cluster detection and enhancing that at the jurisdictional level. Within the Ryan White program, then we really have three areas of focus. One is to continue to reach those people that we have in our system but are not yet virally suppressed, that 10% that aren't virally suppressed. Also, the newly diagnosed. 1 out of 8 people in this country who has HIV has not yet been diagnosed, so we need to do a better job with that. Some of that happens within the Ryan White program. A lot of that happens at the level of the health department and CDC-funded activities. The third is to really focus on people that are out of care, and I do think that's our greatest opportunity among these three. CDC estimates about 250,000 people are diagnosed and out of care. And I know that you all have met those people over time. There's a lot of reasons they're out of care. It can be internalized stigma, external stigma, awful relationship with, when they first came into a clinical experience at one point in time that they're not going to go back. People don't know about it, can't find availability. The patient I took care of last year had been in care for years and moved and lost his job and didn't know about Ryan White and came in with PCP, and that's how I met him. And so there are all sorts of different reasons people have. But a lot of it, as we know, has to do with homelessness and substance use disorder and chronic mental illness and other things. So these people are going to be very expensive to take care of, and it's going to really mean doing things differently with new partnerships. What got us to where we are is not going to get us to where we need to be. This is a classic example. So we have funded jurisdictions. At this point, it's a limited program to certain counties and certain counties with high burden of new infections, and states with a relatively high proportion of rural cases. But in 2023, we funded them at $139 million. So not a lot of money, but they've made a big impact, and I'll show you that in a minute. As well as we fund 2 technical assistance organizations and the AETCs, which once again will play an important role in making sure we're training different providers in different locations to do this work. So we have an infographic here highlighting our year 2 data. I'm going to break it down so you can actually read it. So in 2021, we have 20 data and 2021 data so far. Among those jurisdictions in this program, they were able to bring in 22,000 new patients to care and 15,000 re-engaged patients to care. So with a very small amount of money, they were able to engage 20% of the people who were either undiagnosed or not in care, were brought into care in the first 2 years of this initiative. And I think why they made so much progress so fast, even though they were initially funded literally in March of 2020, was because there's so much pent-up possibility because they've been level funded for so long. And that funding is going, because it's been level funding, to treat the people that are in front of you that need these services. But to reach new people, we set this money aside and said this is new money for a new thing. People took that to heart and said, oh yeah, we did that pilot once where we linked people in the ER to this and that, and it was so successful, but of course we couldn't continue funding it. Or we're doing this in this one small part of the county, we could now do it in a different part of the county. Or we've always wanted to reach out to southern, X county, but we just never had the resources to do it before. So people have made just tremendous progress, and I'm really excited about that work. And just completely new partners and learning a ton of things about working with new partners, maybe in new areas that have very different politics than in the area where the main site is, and making sure your partner knows about managing those politics. I mean, just very, very, very interesting. And excitingly, almost 79% of those clients who were new to care were diagnosed. That were diagnosed new to care were virally suppressed at that end of the first year. So some of those people might have come in October and November, but overall, really high rate given these people are newly diagnosed. And you can see here, as I sort of alluded to, more complicated patients to take care of. Almost 22% were temporary unstable housing compared to 12% in the Ryan White program, and 67% were living below the federal poverty line. So much more difficult to reach for us populations of people that we need to figure out how to reach. The AETCs had an important part of it as well, conducting trainings and training new and different healthcare HIV care professionals. And this is just a laundry list of activities. I won't go over them all now, but I'll just say that it was really around service expansion in a lot of different ways, creating new low-barrier clinics for patients, expanding psychiatry and other services, creating new partnerships with people, instituting gender-affirming care where that wasn't done, and using their data differently to find new clusters and respond to them quickly. So we have, once again, a data summary as well, if you're interested, with more information. We have a qualitative summary, which I think is so important because it reads, it's great reading. May keep you up at night, so don't do it right before you go to bed. But really interesting about how these places have accomplished these new things. And with that, I'm going to end 2 minutes early, and I think we'll turn to questions. I'll turn to Roger. So thank you.
Thank you so much, Laura. And we have time for questions and answers. You can either go to the microphones or use the cards that have been distributed.
Mahir and I will both. I'll be here. I'll be here all day, and Mahir will be here through Tuesday. So I'll be here all week, and Mahir will be here through Tuesday. So please approach us as well.
Yes.
Microphones? No one at the microphones?
All right. Yes, thank you. Okay, so first question here is if we can have guidance on statewide, community-wide, universal eligibility.
Eligibility. Yes. So we can't require any sort of eligibility, way of doing eligibility in the Ryan White program. We don't have any statutory authority to do that. But there are definitely places where they've been able to link their eligibilities between states and cities and community-based organizations. A lot of that, the nexus of why that does or doesn't work in some places is issues around if eligibility is significantly different between the Part C program and the Part A program in terms of income, family income or income eligibility requirements, and data sharing. So that's really been the nexus of it. So that can take a while to figure out, but we have been working on it, and there are many places that actually do it and do it quite well, and that's why we are continuing to do this work, is to really publish and highlight these organizations so that you all can learn more about them and how well they do. We just had a Have You Heard last week where we heard from two places where they've been able to link eligibility across jurisdictions.
There was actually a follow-up on that, which is how do we get the state to, quote-unquote, accept eligibility done by Parts A or C without delaying ADAP for clients because the eligibility staff wants to check all documents all over again?
Yeah, so I think those are just ongoing conversations, and I think pointing out when people aren't getting services and care because of this eligibility issue. We put out that policy clarification notice in 2021 to just try to kind of lower all requirements that we could. But in the end, I've got to tell you, and this has happened, just so you know about the ADAPs, that was ADAPs that pointed out, is the Inspector General of HHS went to a bunch of, long time ago, probably 2010, a long time ago, went to a bunch of ADAPs and said, which of these patients don't you have the right kind of, you can't prove they're eligible. And they made the ADAPs pay back millions of dollars to the federal government because they couldn't prove these patients were eligible in the program. So ADAPs in particular are very sensitive about that, but I think you can do enough of CYA kind of activities to describe what the process is and what you're doing, that audits could look better than some of those audits looked.
Can I quote you on the CYA part? Okay. So, yes, go ahead.
Yeah, Steve Johnson from Colorado. The Ryan White program, of course, is wonderful. I was struck by your slide, though, that shows kind of level funding for parts over many years, despite kind of a time of high inflation and so on. Is there any kind of hope for changes in funding from Ryan White, or should we be happy that we get what we get?
Yes, so I'll just tell you a couple of things. So in some administrations, they were very clear that they weren't going to increase Ryan White funding. They were expanding the health centers, and that the health centers could take care of people with Ryan White, people with HIV. And so at that point, we started working really closely with health centers to help them expand what they do in HIV. But most of them don't do a lot in HIV unless they get some special HIV money, some of which now they get directly from the health center program. So that has worked a little bit as like the other way it's going to happen. In the current House bill for funding in 2024, and the House and Senate have to both have bills and agree that the Senate is largely stable over time, and the House has zeroed out the Part F program, which is AETCs, the Part F dental program, and the SPINS program, and they've zeroed out the EHE funding. So I don't think it's going in the direction so far, and we'll see where that ends up. But I think there are so many competing priorities right now in healthcare, in health, that we're always hopeful that something might change. But that's not looking like it's going to happen in 20. We'll have to see where 24 ends up. 24 is going to be a tough year.
So the next question is also about funding. We have heard that the ending the HIV epidemic funding may be ended early. Is this true?
So I think that comes from the fact that in the House markup of their bill, it's at zero. Not just for us, but sort of across the board. In the Senate markup, it's not. So once they come together and decide what the funding level is going to be, then we'll know. But until then, it's a complicated. Any of you that follow any politics, it's a complicated year for where the federal budget's going to end up this year. We will see. We can demonstrate it's been very, very successful.
All right.
Hi, Adam Lake, Lancaster, Pennsylvania. I'm guessing that there's a lot of folks here that maybe work in large healthcare organizations or with university programs, and we're, compared to the rest of the healthcare system or university, we're relatively small. And for example, when I'm going and talking to people that need to allow us to, say, renovate a space or hire additional staff, they're often wanting to make sure that, oh, this is, okay under Ryan White, and then they try to look at the policies, and there's 30 years of policy clarifications and letters and FAQs, and they quickly get overwhelmed and try to, basically, my word doesn't seem to mean very much. So I'm wondering if there's been any talks or efforts about trying to have any sort of certification program that maybe somebody in each program could be, go through a certain training and get certified as kind of, yes, we understand a certain amount of Ryan White, and hopefully earn some trust of those above us who are looking at us to stay in compliance and make sure that we don't run awry of federal regulations.
So I've never been asked before. That's really interesting. I'll take that back to our grants management people who would probably, would be the people that would be in charge of something like that to figure out what it is. To see what the possibility, I hear what you're saying, to see what the possibilities are. And sometimes it's sort of like, sometimes you call up some part of government and get one answer, and you call up 3 days later and get a different answer, and that's also frustrating. So, yeah, I'll ask them about how to help with that.
It's also challenging, just I understand the reluctance sometimes to put things in writing. So we might be told something directly by our program officer, and then our lawyers ask for it in writing, and we can't necessarily get it in writing per se, because I understand not wanting to establish precedent or policy, but it does make things a little harder to move forward.
Yeah, but you should be able to get an answer in writing. I'm looking at Mahir. Yeah, you should be able to get an answer in writing. We had a question, for example, about gender-affirming care that was kind of complicated. And so we'd actually gotten 2 or 3 kind of all at the same time. So we put out a program letter where we laid it all out because it was easier to do that way. We've gotten sometimes very specific questions about, appendectomies are sort of outpatient. Isn't that outpatient care now? And we're like, no, it's not for these reasons. And we'd send it back in writing. So you should be able to get something back in writing. We don't have construction authority in Ryan White, but we have renovation authority, as you know. In the health center program, they have construction authority. So, but you should be able to get something in writing about what exactly, what that would look like, and say, is this considered a renovation? And they can say a renovation is considered X square, changing your footprint, not changing your footprint, whatever the qualifications are. They should be able to tell you those things.
Yeah, on data you presented, somebody wants to know if you looked at viral suppression rates in women, as opposed compared to men.
Yes, we have looked at viral suppression rates in women, and I don't know what they are off the top of my head, but we don't have any groups where we had big disparities we put on those slides, so we do not have significant disparities. Now, you look at different young women, different groups of women are going to have some disparities. But I can come back with that I have that, yeah.
Okay. Thank you. The next, I don't know if it's a question or a statement, is on case management. Is there an expectation from Ryan White to have outreach workers assist with enrollment into Medicare, Medicaid by our clients' patients?
Yeah, so we don't have any requirements with outreach workers. A lot of eligibility specialists, I think, are often clinic-based because they're filling everything out online, but you could certainly do that in the field as well. We do highly encourage outreach workers because that is how we're going to get to people that aren't in the physical walls. I think a lot of you who have some really great model programs where you're extending the walls of your clinic, whether that's a mobile clinic or outreach workers into the community.
Okay. The next question is Ryan White collaborating with states to address the housing concerns of people living with HIV? That is, anything to address affordable housing for vulnerable populations?
So that's a great question. We are not working with states to try to have states improve their housing. I think we're working with HUD. A lot of places the issue really is housing stock or affordability of the housing that exists. And so that's not something, frankly, that we're going to be able to fix with Ryan White programming. It's not something you're going to be able to really fix with HOPWA programming. It's a much broader issue. So I think we have focused on, for example, leveraging our relationships beyond HOPWA. So HOPWA is a small program within HUD. And so last year, we worked, since the beginning of this current administration, we've worked really hard to broaden our reach into other parts of HUD and the other housing programs that are much bigger than HOPWA, to figure out what we can do differently to decrease barriers to both in terms of some of the stigma that LGBTQ populations have in some of those housing authorities, as well as people with HIV in those housing authorities. So we're taking it more at the federal level, because Ryan White is not going to, that underlying problem, it's a huge structural problem that Ryan White is not going to fix, and the funding we have doesn't even begin to approach what we need for people with HIV.
All right. Thank you. And this is a 2-minute warning for the end of the session. So, did you say that AETC funding is going away?
No, I did not say that. I said that in the current House bill for appropriations for 2024, they have zeroed it out. Now, there's a long way between where the House bill and the Senate bill are around appropriations and what the final outcome is of a bill, right, of the final appropriations bill for 2024. But right now, that's where the House put down their first marker. The Senate put down their first marker as stable funding. And then they're going to have to reconcile those bills over time. And usually when they reconcile bills, they don't necessarily meet halfway. That's not the way that this process works. But that is where the House mark was for 2024.
All right. Thank you. I do not see other questions, and I've read all those I received. So thank you so much, Mr. Chairman.